The next speaker is Dr. Arun Kumar Jain. I'm sorry, sir. There's some one thing went wrong with copying.
All right, it's okay.
Or post-traumatic toric ICL. I have no financial disclosures. A 29-year-old male presented to us with complaints of glare and difficulty to open eyes in 6 months. It was status post-blunt trauma. Patient has a history of both a toric ICL implantation in 2019 for high refractive error. So on the day of presentation, on ocular examination, we found that the visual acuity was minus 0.5 spherical and minus 1.5 cylinder in the right eye with 6/9 vision, and IOP was normal. On anterior segment examination, we found that the cornea was clear, but the pupil was peaked at 8 o'clock with haptic in AC. And now our management plan was to reposit the ICL. We had to ensure that when we reposit in the same axis of 16 degree as it was originally done during the surgery in 2019. So after ICL repositioning, on postoperative day 1, we found that the best corrected visual acuity was 6/9, IOP was normal, but on anterior segment examination, we found that the iris is atrophic and retracted at 8 o'clock. We did AIOC and we found there was a high wall centrally as well as in the peripheral area where the pupil was atrophic. So now the patient has atrophic iris, patient still has complaints of glare and a high asymmetric wall. So our plan was single pass 4-throw pupilloplasty. In this technique, before we give the peribulbar anesthesia, we mark the visual axis as well as we mark the axis of astigmatism of 16 degree. Now the conventional steps of single pass 4-throw pupilloplasty is performed. The incisions are made. A single pass of needle is done through the edges of the iris defect. The suture end is then passed through the loop with the 4 throws as conventionally described, and the knot is then tied. After 1 week post-pupilloplasty, we found that the patient has best corrected visual acuity of 6x parts and the pupil is now round and regular. On AIOC, the wall got reduced and patient symptoms got resolved. Take-home messages that to educate the patients to report early in case of any complication.
No, Arun sir. Nice technique, sir. Really hats off to you to have the courage of doing it in a ICL case. Mild submicron level. Many were you can go either ways. The only question I have is was there any pinhole pupil effect, sir? After that?
No, the pupil, we dilated the pupil also. You can, it becomes...
No, we can dilate it, but on the refraction, was there any pinhole effect on the refraction?
No.
Because the pupil size in either of the eyes will vary, isn't it now?
This was first day because it was a little bit pilocarponized, but it increased to 3 to 4 millimeter later on.
Okay.
And because the shortage of time, we didn't put the eye trace graphs of quality of vision before and after.
Okay.
They were two-way different.
Okay.
Lot of aberrations in before SFT and compared to post SFT. And though you said clearly it's a very difficult situation, if you go haywire, you can create cataract.
Yeah, you can create
this, in this case. So it was quite satisfying for the patient in terms of glare, visual acuity, and we advise the patient they should come early. He waited for 6 months at home, so iris became atrophic. We try to center it in the first surgery when we aligned the IOL and put the haptic back, but the bleeding started, so we didn't do it at that time. We tried to do a visco dissection at that time. With pilocarpine, we tried to constrict it, but it was atrophic. As you can see, the pupillary rough is also absent in that area. So it was there is no case report. I tried to search the literature. There is no case report of doing SFT in a case of ICL as such. So we advise patients they should come early if they don't come early. And in this case, special thing is you have to mark the visual axis before giving peribulbar, because you are handling iris, visit painful, and you are passing 2 sutures, and if patient is moving, you can hit the lens. So you have first to mark the visual axis, not the center, not the pupillary axis, the visual axis. Coaxially sighted central corneal reflex, and first we mark also the axis of the orientation of the ICL also by very
Yeah, this was my
very
second question to you.
That
Yeah,
was also
So
because the
chances
toric
of,
ICL.
yeah, it was a TORIC ICL. So before giving ICL, let the patient lie down. We had the Varion data from the Varion. With the Varion, we marked the axis at 16 degree, then marked the coaxially sighted central visual axis reflex, and then gave peribulbar, and then planned our suture in such a way that pupil centers onto the visual axis rather than pupillary axis. Otherwise, you will have less than chord mu should be taken care into. Chord mu, yeah, angle
Yeah,
alpha,
that-
kappa.
So this was in the horizontal axis in the peaking of pupil was in the
This was
horizontal.
at around 7:30 to 8 o'clock
7:30.
meridian.
7:32. That's why. If it would have been in a superior part under the lid, upper lid, then we could have left it like that.
It all depends upon the quality of vision. If it doesn't affect the quality of vision, then you can leave it like that. But the vault was also asymmetric because the pupil became little bit atrophic and floppy in that meridian. So the vault was little higher on that side as compared to the other side. That's why we got a little astigmatism. Before first surgery, post-operatively, we didn't have any astigmatism. Because the asymmetric vault and a little tilt of the ICL, we had a astigmatism also.
Yeah. This was, I think, after the procedure, it was 0.5 diopters
Yeah,
only,
yeah.
and before it was
It
1.5.
was much more. Yeah.
Very nice,
So
sir.
we took
What
the,
viscoelastic did you use?
so in this case we used the
Sodium iron?
Helon plane. We injected behind the iris and in front of the iris so that you have a space to work.
Okay.
Otherwise, you will be hitting the ICL or the
ICL.
lens, or otherwise. You have to create a space.
Behind it. But
Yeah.
already the space is less in most ICL
Yeah, but it's a
cases.
very large myopic eye, 27,
Okay, so
13 diopter of refractive error, deep AC, all those things. Yeah.
Very nice.
Very nicely managed, sir.
nicely managed.
Superb.
Thank you, sir.